Well, greetings everyone and welcome to the EKG case for the week of February 10th, 2014. I've got a quick but really great case for you this week. This week's case was actually sent by Dr. Sean Fox, who is a former resident who is now on faculty at Carolinas Medical Center, a fantastic program in Charlotte, North Carolina. And it actually wasn't his case, but it was a patient that was being taken care of by one of his faculty colleagues, Dr. Russ Kearns, and one of their outstanding senior residents, Dr. Mike Merrill. It was I guess a middle-aged gentleman who had presented to the emergency department complaining of chest pain. He started out with this pre-hospital EKG, and this is the one that we're going to talk about. The EKG that they obtained in the emergency department wasn't really a whole lot more interesting. This is a really great EKG that's worthy of some discussion. Now, because it's a pre-hospital EKG, it's a little bit longer than I'd prefer. So what I'm going to do is I'm just going to split this down the middle and put the limb leads up top here. So you've got your limb leads up here and you've got your precordial leads down here. Take a look, and what do you think is going on? Now, obviously there is ST segment elevation in a handful of the leads there. You've also got some beautiful PR segment depression in several you've got some PR depression in a bunch of the limb leads. You've also got some PR segment downsloping in some of the precordial leads. And with the ST elevation in more than a single coronary distribution, it sure as heck seems like this is acute pericarditis. And, the computer called it acute pericarditis also. Now, we've talked about what you need to do when you're trying to make the distinction between acute STEMI versus acute pericarditis. And the problem that oftentimes gets made, certainly by the computer and by many clinicians as well, is that the first thing that they start to look at is they go right to that PR segment depression, which really does jump out at you and would make you think that this is acute pericarditis. Now let's go back through what we've talked about many times before in this video series. When you're making the distinction or trying to make the distinction between a STEMI versus acute pericarditis, I don't want you to look at the PR segments yet. What you need to do is take a look at some of the other findings on the 12-lead EKG, which would lead you to call this a STEMI first. So step number one, look for the things that would rule in STEMI first. You're going to look for signs of ST segment depression. Now, we can ignore V1 and AVR because ST depression in those two leads can be fairly nonspecific. But if you see ST depression in any of your other 10 leads, it's a STEMI. You're done. Don't look any further. Step number two, look at the ST segments in leads 2 and 3. And if there's ST elevation in both of them, compare them. If there's elevation in 3, which is greater than in 2, you're done. It's got to be a STEMI. Don't look any further. The other thing that you'll do is you take a look at the morphologies of the ST segments. If the ST segments are horizontal or convex upwards, like a tombstone, that has to be a STEMI. Pericarditis is only allowed to give you concave upwards ST elevation. But STEMI can do anything, and if you see either of these two, it's got to be a STEMI. Pericarditis is only allowed to give you that type of ST segment elevation. And then finally, if you see Q waves and you know for sure that they're new, then that can be helpful. But, oftentimes you don't have old EKGs for comparison, and so you may not know for sure that the Q waves are brand new. So that's often not helpful, and you're certainly not going to just sit there and wait a few hours to see if Q waves develop, right? Well, once you go through these first steps, then you can move on to step number 2, and it's not until step number 2 that you start looking for PR segment depression. And the reason that we continually say is don't look at the PR segments until you get past step number 1 is because PR depression is not specific for pericarditis. You can see PR segment depression with atrial infarction or ischemia or abnormal atrial repolarization or other types of ischemic conditions, including STEMIs. STEMIs can produce PR segment depression, and the computer doesn't know that, and that's why the computer was calling this a case of acute pericarditis. But if you go through your steps, let's take a look at what happens when you actually go through your steps. So, step number 1, we're going to ignore AVR and we're going to ignore lead V1. Is there any ST segment depression in any of the other 10 leads? If there is, you've got to call this a STEMI. Nothing may be 100%, but it's pretty darn good. Now, I would say that if you look carefully, you might see some ST segment depression in lead AVL and maybe in V2 also. Now, some of you might say, well, that's kind of a soft call, maybe in V3 as well. Maybe that's a soft call. Fine. If you move then to the next step is take a look at leads 2 and 3 and compare the ST segments. Is the ST elevation in 3 greater than in 2? If it is, you've got to call this a STEMI. And in this particular case, it is. The ST segment elevation in 3 is greater than the ST segment elevation in 2. And so that is another reason why you've got to call this a STEMI. The third step, do you see any horizontal or tombstone type of ST segment elevation? I don't know. I don't think you really do see any of that. But at the very least, the ST elevation in 3 is greater than in 2. This has to be a STEMI. And Dr. Fox's colleagues were smart enough to pick up on that. They did a cath lab activation. They sent the patient to the cath lab, and what they ended up finding was that there's a critical occlusion of the LAD. When they tried to open it up, the patient crashed. They ended up needing to send the patient for cardiac bypass surgery for an occluded LAD lesion, and I think the patient ended up, fortunately, doing well. So great pickup to all you folks at Carolinas for picking up on that, because the computer, and I think a lot of other people, would have looked at that 12 lead and said, based on the PR segment depression, that sure as heck looks like pericarditis. But again, don't look at the PR segments until after you've gone through the other steps first, because PR depression is not specific for pericarditis. The myth that we've all been taught back when we were in medical school and in residency. Look for signs of acute MI first, then you're allowed to look for PR segment depression. All right, so simple, quick case this week. My thanks to Sean Fox and his colleagues at Carolinas. Great job, and I hope that was helpful. And I look forward to talking to all of you next week. Bye for now.
This is our young man here who's got a jaw dislocation, recurrent jaw dislocations. And you said, ma'am, that it began after he had a seizure 3 years ago. Is that correct? Mm-hmm. All right. And then he's had it ever since then. He's having them even without seizures.
Right.
Okay. All right. He's had some medication, so he's a little bit sleepy, but he's very willing to be a movie star today.
Yeah. We've had this done before. All right. We ready? Here's 60. You're going to be going to sleep here soon, okay? Yep. It's all right.
All right.
All right, Eddie. Yep. Boy, get over here.
Come off to line one. Come off to line one.
There, filled it. No, still not.
We got one side.
Yep, I think I did. Felt something going. Which side? This is about. I think it's the right side. Alright, buddy. Alright, it's going in.
What do you think? Is
Is that lining up?
does that look about right?
Yeah, yeah.
Yeah. Alright.
Yeah, feel it pop in.
Now you just gotta
Hold it.
grease both sides and
Alright, so all the way around his head?
You go all the way around this way, then you go like this way.
Mom knows.
It won't come off.
she'll tell you.
I'm so nervous, John.
Alright, so let's take that off for a second. Now, adjust that afterwards. Need to worry about. That was the thing, I'm like, okay, I felt a pop, but then it wouldn't close, and then I checked again and it closed.